Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
We'll let Mindy go ahead and take over here with the next section, talking about some clinical evidence of the novel therapy options.
Excellent. Thank you. Good evening, everybody. Thank you for joining us. And I am going to move on and really talk about some of the individual products that have already been introduced. So thankfully, the groundwork has already been laid for this. And we'll just talk about some of the trials. So if we're thinking about non-replacement therapy and hemophilia treatment, as has already been mentioned, there's different categories. So if we think about this rebalancing, right now there are two options, and that is either targeting the antithrombins. We've got an antithrombin, it's a silencing RNA product, fitusiran, which is still under review, going through clinical trials. This product is currently under study for subcutaneous injection either monthly or every other month. The initial stages of the trials, there were some thrombotic events that led to an adjusted dosing regimen. So currently, the target of the dose is to maintain patients with antithrombin levels between 15 and 35%. The other category of these rebalancing agents that are now commercially available are targeting this tissue factor pathway inhibitor, so anti-TFPI products, where we have two. These are recently approved. Concizumab is a daily subcutaneous injection. This product is now approved for patients with inhibitors, including hemophilia A or B. There were some thrombotic events early that led to, again, a targeted approach. So the dosing for this is adjusted with concizumab levels. And then the other product is marstacimab. This is a weekly subcutaneous injection. This one is currently approved for patients without inhibitors, again, targeting either hemophilia A or B. And so far, there's been no thrombotic events. So this is one that is not as level-based. And then we have a category that we've become much more familiar with the use of emicizumab through the last several years, which is this factor VIII mimetic. And there is a newer product called Mim8 that is still going through phase 3 trials that is currently being looked at as weekly or monthly subcutaneous injections. And this, of course, because it's a factor VIII mimetic, is really only targeted for hemophilia A. So if we start with the antithrombin, the fitusiran, these were the ATLAS trials, and in this case, the ATLAS AB was looking at patients without inhibitors, and this is just showing the median observed annualized bleeding rates, or ABRs, for treated bleeds during the treatment period, and for those that were treating on demand with clotting factor concentrates, it should be no big surprise that they had much more bleeding than those that were on prophylaxis, but the fitusiran prophylaxis had very little bleeding, as you can see. If we go to the next one, this is the ATLAS INH trial. This is for the patients with inhibitors. And again, when we're looking at the primary efficacy outcomes, it was a comparison of those on demand to those on fitusiran prophylaxis. And again, the ABRs were substantially higher in those on demand and significantly lower if you were using prophylaxis. And the number of patients that had zero bleeds during this treatment period, one patient on demand had zero bleeds, but 66% of the patients on fitusiran prophylaxis had zero bleeds during this. So again, highlighting the effectiveness of this therapy. As I mentioned, there were some thrombotic events early that led to some dose adjustments, and in reality, those were all based on lower levels of antithrombin. And so there was an adjustment where basically the target level was raised to kind of this 15 to 30%. And that's now this ATDR, or antithrombin dosing regimen. And with that, we have not had further thrombotic complications, and the bleed rates remain low. So on the new adjusted dosing regimen, regardless of if you were an inhibitor patient on either bypassing agent prophylaxis, which is the green, versus fitusiran prophylaxis, which is kind of the aqua color on my screen here on the left, still had substantially improved bleed rates when you were on fitusiran prophylaxis. Those without inhibitors that were using clotting factor concentrate prophylaxis, again, had lower bleed rates when using fitusiran. If we move into the anti-tissue factor pathway inhibitor products, so the first one being concizumab, this was the Explorer trial. So Explorer 7 was the original study looking at concizumab in hemophilia A and B. And this was looking at the comparison of, no prophylaxis versus concizumab prophylaxis, where the primary endpoint, again, is bleeding, including treated spontaneous versus traumatic bleeding episodes, and there was significantly less bleeding on concizumab prophylaxis. In all categories, there was less bleeding if you're looking at either, spontaneous bleeding, joint bleeding, target joints, or all treated. In the Explorer 8, this one was looking again, at this hemophilia A and B. They randomized 1-2 to no prophylaxis versus prophylaxis with concizumab, and the primary analysis in this was again regarding bleeding rates, and again, the concizumab prophylaxis group had substantially lower bleeding rates in all categories in both hemophilia A and B. So there was definitely superiority proven with concizumab over no prophylaxis. And when you look at the group that then, for those that started on demand, they all had the option of then switching to concizumab prophylaxis after they finished the original on-demand weeks. And so this is kind of an intra-patient comparison in terms of, going from the on-demand to the prophylaxis, patients that started with target joints versus those that started without target joints. Those that had, on prophylaxis continued to do well and have low rates of bleeding. And then in this case, looking at the marstacimab product in terms of the alternative anti-tissue factor pathway inhibitor. This is data from the phase 2 trial. And in this case, this is most of these patients came and rolled over from earlier studies. And so they grouped them into 6 cohorts, and including the dose that they had started on in the previous trial and then what they came into. So cohort 1 started with 300 milligrams and continued on that dose. Cohort 2 was on a 300 milligram loading dose, followed by 150 milligram maintenance dose. And they came into this phase 2 trial on same regimen. Cohort 3 started on a higher dose, but had a decreased dosing strategy when they came into this phase 2 trial. Cohort 4 was inhibitor patients, and these stayed on the 300 milligram. Cohort 5 was an adolescent group that didn't enroll, so that's not included in this table. And then cohort 6 were patients that were not previously on the earlier studies and came in as a de novo group, starting on the 300 milligram loading dose with 150 milligrams with inhibitors. And this is showing the difference between their pre-treatment annualized bleed rates compared to once they were on treatment, showing the significant improvement in annualized bleed rates with far less bleeding on the marstacimab prophylaxis. So marstacimab is administered weekly. It's a flat-based dosing. This is not dosed adjusted on levels. And the current approved dosing is to start with the 300 milligram loading dose, followed by 150 milligrams weekly. There were over 100 patients that were treated with this during a 1-year period versus prophylaxis and on-demand. And the as we showed on the previous slides, essentially they had a markedly significant reduction in bleeds when they were on the prophylaxis, and so results really showed superiority compared in the annualized bleeding rates. And the safety profile was consistent with the earlier phases as well, and generally treatment was considered well tolerated. In this case, it just shows kind of the types of bleeds. They didn't change as much other than maybe some more traumatic bleeds when you were on the routine prophylaxis. So this is the on-demand versus routine prophylaxis. There were more bleeds early than on the on-demand than in the routine prophylaxis, but the types of bleeds were fairly similar, with on routine prophylaxis having a slight increased traumatic bleed rate and less of the spontaneous, which of course would be what we would like to see, less spontaneous bleeding. So if we go to more of the substitution-based therapies, so MIM8 was looked at for, of course, hemophilia A. So this is the factor VIII mimetic. And this was done through the Frontier studies. The Frontier 2 is a phase 3 open label randomized study looking at the efficacy and safety of MIM8 in males and females, adolescents aged 12 and up, so adolescents and adults, and it was with or without inhibitors. There were over 250 patients that were randomized, and the MIM8 was administered using a tiered dosing. And from an efficacy standpoint, those patients, in patients that were previously treated on demand, the estimated ABR on either the once a week or once a month dosing prophylaxis was significantly improved compared to those prior ABRs when they were on demand treatment. And so MIM8 prophylaxis was superior to on demand with a reduction of 97% or 98% ABRs. In those that were previously on clotting factor concentrate prophylaxis, again, there was a significant improvement in annualized bleed rates. It's less dramatic than those that were on demand because thankfully prophylaxis has worked for a long time. And now we're in a nice kind of fine tuning stage of trying to just keep getting less and less bleeding. But again, even for the once a week or for the once a month dosing regimen, there was less bleeding. And there's an ABR reduction of about 42 to 48% on these two regimens compared to the clotting factor concentrate prophylaxis. And from a safety standpoint, there were, over half of the patients had zero bleeds in those that were treated on the MIM8. There were really no safety concerns or no clinical evidence of neutralizing anti-MIM8 antibodies. And really the major, if you want to call it major, issue is that a few patients do report some injection site reactions, but it's 5 to 12%. In these studies, they also look at patient-reported outcomes. So what does this mean for patients, and is it really impacting them and their ability to care? Manage their disorder, and does it help with the things outside of just bleeds? And so patients, they did look at different elements, especially in things like physical functioning, treatment burden, and all those things that Dr. Roberts had mentioned in previous studies that were targets of what we really are trying to do. So, the MIM8 prophylaxis was associated with improved physical functioning, reduced treatment burden compared with on-demand treatment and baseline. And among those that were previously on clotting factor concentrate prophylaxis, the physical functioning improvement was to a lesser extent. And for those that had joint pain intensity wasn't as severe at baseline in all arms and didn't change notably with MIM8 prophylaxis. But, really shows that there are holistic benefits of this product beyond just bleed protection. The Frontier 4, this is the open label extension study, continuing to follow these patients that have been on these studies. And this is really just looking at the tolerance and the safety, and just highlighting that really this MIM8 prophylaxis has been well tolerated. No patients have discontinued treatment through 26 weeks of this open label extension. There have been no thrombotic or safety concerns that have been reported. And in this extension phase, 84% of patients had zero treated bleeding episodes. All right, and then tackling a little bit of the gene therapy. So valoctocogene roxaparvovec, which Valrox is an easier way of saying it, in hemophilia A. This was from the Generate-1 trial. This was a phase 3 open label single group study. This is the current product that is FDA approved for hemophilia A. This looked at 134 adult men with severe hemophilia A, factor VIII levels less than 1%. And it significantly increased factor VIII activity and reduced bleeding and factor VIII use. There were 16% of patients had reports of serious adverse events. But you can see the factor levels, the factor VIII activity levels. There's wide bars of what factor VIII activity levels they achieved. Most patients were able to come off of prophylaxis, though, and we have data now several years out following these patients. And essentially, the bleed reduction rates are significant. So, from reduction rates of 80 to 98% after treatment. So we have now data up to 7 years after the early start of the Valrox trials, and looking at the adult patients, severe hemophilia, who had received one of two dosing regimens in these early phase studies. So they're and now followed either 7 years or 6 years, and the continue to have low infusion rates compared to the baseline values, and continuing to follow on safety data. At this year 7 and 6, the mean factor VIII activity was about 16% and 6%, depending on the two dosing cohorts. So really leaving these patients continuing to live in a mild hemophilia range. From a safety standpoint, one participant did have grade 1 hepatomegaly, one has had grade 1 splenomegaly and hepatic steatosis, and 2 participants have returned to prophylaxis. This is another factor VIII gene therapy that's currently undergoing a phase 3 study. This is the Affine gene therapy trial, and there have been 50 patients that have been included in the efficacy population in this study. The total ABRs are significantly lower, and at 15 months, 84% of the participants had factor VIII activity levels that were over 5%, so at least in the mild range. The number of infusions have gone significantly down from after treatment. One dose participant has resumed prophylaxis about 16 months post-infusion, and about 20% of participants had reported some serious adverse events, including things like fevers, increased liver enzymes, headaches. This is another product that was mentioned. This is also continuing in clinical trials. This one has so far had 25 participants that were enrolled against in several dosing cohorts and have been followed up for over 200 weeks. The median ABR is, again, much lower than in the historical for each of the patients. Of course, there's far fewer infusions afterwards. There have been 66 treated related adverse events, and no factor VIII inhibitors or thrombotic events have occurred. And again, similar to other agents, there have been some transient liver enzyme elevations. For hemophilia B, this is the etranacogene dezaparvovec gene therapy, the HOPE-B. This was a phase 3 study in adults with moderately to severe hemophilia B, single dose. They had 18-month safety follow-up. They had 54 participants and now have entered into long-term follow-up for up to at least 5 years. And we have data from the first 3 years. ABRs were all significantly lower, and of course improved things like joint bleeds, whatnot. And the much less, of course, need for factor infusions. Of the 52 participants who expressed this, there were 2 participants that did not. One got a partial dose and then had an infusion reaction, so only got about 10% of the dose. They did not respond. Another patient, this particular product did not exclude patients based on pre-existing antibodies, and the other participant that did not respond had a markedly elevated pre-existing antibody. But everybody else it did have a response, and of those, 51 are continue to be free of target joint bleeding up to 3 years later. This is the FIDA in the hemophilia B. So this had 60 participants. This is the Benagene 2 trial. This, again, is another product that is currently approved for hemophilia B. This had, over 200 patient participant years of follow-up, and really this was very similar in terms of the expected things like liver transaminitis that typically occurs early on after the treatment, and there's been no participants have needed steroids after the year. And there have been no deaths or discontinuations due to adverse events, and similar, we're following these for long-term follow-up and monitoring the long-term efficacy and safety. Thank you for joining us in this episode of Talking Hemophilia, Clinical Evidence on Novel Therapy Options in Hemophilia. Please return to the landing page to access the third episode of this series.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.